Everybody, and welcome to Tuesday Training. I hope you're having a fantastic week. As always,
we are live from Austin, Texas, right here at Insurance Syndicate headquarters, and man, we have a great show for you.
Good morning. How you guys doing, man? Thank you, Luz. It is good to be back. I will say I had a spectacular time touring Europe for 24 days, but it is good to be back, let me tell you. We had a lot of fun, man. For those of y'all that followed me on Facebook, I appreciate the support, the engagement, the laughter, because we definitely had some of that. But we had 24 days. We went from Portugal to Barcelona to the French Riviera, right, the Côte d'Azur, and then Rome, Naples, Pompeii, and Amalfi Coast. We had a blast. It was a lot of fun. So if you've not been to any of those areas, I highly recommend you go. Especially go to Rome. If you haven't been to Rome, it's fantastic. And the people while we were there were fantastic. Only ran into two people that were not friendly. One of those was an airport security guard in Porto, Portugal. She had zero interest in being of any assistance. And one French taxi driver. Whatever. I think all taxi drivers are kind of assholes anyway. Everybody else, super cool. It was an awesome trip. So thank y'all. And it is good to be back. And we've got a bit of a hot topic lined up for today. I was going to go through a couple of news items, but there's nothing like super crazy. I did post something in the group late last week called the Medicare Advantage Improvement Act of 2026. You will see that in the group. That bill, which I believe is sitting in the House right now, is basically an effort to clean up prior authorization in the Medicare Advantage world. Sounds great in theory, like we all want less denials, less improper denials especially. But if you think of some of the issues that have been happening in the Medicare Advantage world, you know, with some of them reducing commissions, reducing their footprint, complaining about their profitability, et cetera, those prior authorization efforts are designed as cost controls. So if they remove those cost controls from them, where else are they going to make up that money? Something to think about. So keep your eye peeled on that one. If I see any updates, I'm of the opinion it'll probably get shot down. You know, I think the lobbyists in healthcare probably have way too much money to get them to push that through. Maybe they'll make some, maybe they'll loosen a few items, but they're not getting rid of PA, man. But what they're trying to do with that bill is they're trying to get prior authorization on par with Medicare, right? Medicare only does prior authorization for a handful of items. They expanded that a little bit, mostly nerve stimulations, certain skin grafts, things like that. So they're trying to get Medicare Advantage plans to run on the same level of prior authorization that original Medicare does, which means they would give up a lot of their PA efforts, which again are cost controls. So we'll see how that goes. I'll keep y'all informed. But other than that, I just want to dive into the topic today. If you're tuning in and you remember, I brought up, I shouldn't say I brought up because I didn't bring it up, but I wanted to investigate this idea and kind of poke some holes in it or prop it up. Like, I'm open either way. I'm open to being wrong as well. I won't say that I'm wrong because I really don't think that I am. I will stand by my belief that Plan N is a better choice than combining a high deductible Plan G with the Hospital Indemnity. But as with anything in the Medicare space, when you're dealing with 50 states, changing geography, all the states have their own regulations and rules, product availability, et cetera, et cetera. There is no absolute, right? Certain states, high deductible Plan G with the Hospital Indemnity plan makes a lot of sense. Like, look at Florida. Like, Florida is definitely one of the anomalies when it comes to Medicare supplement rates because they are extremely expensive. And they're not community rated or anything. It's not like a Connecticut or Maine or Washington State or New York where they're community rated, guarantee issue all the time. They are just damn expensive in Florida. And that is primarily just because of the volume of business. And let's be honest, who lives in Florida? Bunch of Medicare beneficiaries. So rates are definitely higher there. So as an example, in Florida, and I went to the worst case scenario in Florida just to tee this up. But like a plan in for a 65-year-old female in Miami is $230 a month. A high deductible plan G in Miami for that same 65-year-old female non-smoker is $65.16. That is about $165 difference. That's a lot of coin. So plugging in a solid hospital indemnity plan there actually makes pretty good sense. I mean, in a lot of cases, especially in a place like Miami, your MAPDs are still going to make more sense from just the total cost standpoint because they have MOOPs that are just ridiculous. Whether or not those MAPDs are viable for long term, and you're going to continue to see MOOPs, max out of pockets in Miami area, South Florida, that are $300, $500, $1,000. I don't know how long term that is, but as long as those still exist, that usually is going to be the go-to product. But for people that still want freedom of choice, people that still want to be able to travel, yada, 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 getting them on a high deductible plan G there and pairing in a low-cost hospital indemnity plan is not a terrible idea. That's Florida. Other states, not so much. Other states, I'm going to stand 10 toes tall that plan in is the smarter choice. Is it always the cheapest choice? No. But if we're always only selling on cheap, if this argument of plan in, as an example, or high deductible plan G plus a hospital indemnity, if we only frame the argument based on lowest premium, well, then MAPD is going to win the whole time because you can't beat $0 in premium. Like that's always going to be the cheapest argument, right? So what's the purpose of, let's just go through kind of the top and frame the problem. What's the real problem here? What's the real benefit of having a Medicare supplement plan or a Medigap plan versus Medicare Advantage as a whole? It's access to care is the primary thing, right? At least that's my opinion. Cost controls, because with the Medicare supplement, you know exactly what you're spending month in and month out. So I can budget my premium. I can budget my deductible as I go visit the doctor throughout the year. I can budget my $20 copays, etc. But the real upside, like the real selling point to having a Medicare supplement plan versus an MA is ultimately access to care, because no matter what Medicare supplement plan I have, whether I have plan A or plan F or plan high deductible G or plan N, my access to care does not change. I can go to any provider that accepts Medicare in all 50 states plus Puerto Rico. I don't need referrals. I don't need permission. I just have to verify that that doctor accepts Medicare, which 99% of them do, and that he's accepting new patients. And then I can kick open the door and walk right in. Medicare Advantage, we already know, is a network-driven product. Even with the PPO, you have conditions on when you can go out of network. And when you do go out of network, cost goes up. So that's the primary selling point, right? Is access to care. That's why someone wants a Medicare supplement plan. So if the problem then, as Josh has pointed out here, that rate increases on plan in versus guaranteed renewable HIP properly set up, right? There have been some high increases on plan in as well as other plans, but some of that is also bullshit. Some of that has been anomalies, and I have the data to back up that statement, and we will look at rate trends across several of the Medicare supplement plans in this episode. I'm told y'all I'm bringing some receipts. So we're going to look at rate trends. We're going to see how much truth there is that, oh, plan in has these high rate increases. Yes, it has had some, but still historically, it's got the lowest trends in the market, right? Period. Except obviously, and when we look at high deductible G, but even some of their rate trends have been pretty high, right? But 10% of a high deductible plan G versus 10% of any of the other plans is obviously less money, right? Anyway, so again, the real problem is they want the people that are considering bouncing from an MAPD and they're looking for the lowest cost premium. So they're examining high deductible plan G 100%. They're doing that because they want the access to care. They want the ability to have freedom of choice to choose their doctors. Understood completely. And they're also okay with self-insuring, because what is the deductible on a plan, a high deductible plan G? It's $2,950. And that's good for Part A and Part B services. So almost the first $3,000 is on that beneficiary before the plan kicks in at all. Okay, no big deal. If they're cool with that and they don't mind it, absolutely. I mean, before High Deductible Plan G came out, we had High Deductible Plan F. When I was in the field full time from 2004 to 2008 or 2009, I was selling a fair amount of High Deductible Plan Fs. And the deductible wasn't nearly as high back then, right? I don't even think it was $2,000 back then. But there were a bunch of engineers that I got introduced to in the oil and gas space, and they all wanted what Pat had, and Pat had a High Deductible Plan F. So I wrote a bunch of them. And they were told, and again, the purpose was they wanted access to care. Back then, we didn't have MAPDs anyway, so it's not like I even had that option. So it was either you just have original Medicare or let me get you this product. They all wanted it. Worked great. So I have nothing against that. So I want to be clear about that. This isn't an episode where I'm going to beat up High Deductible Plan G and say it's a bad product. I do not think that at all. I'm not going to beat up MAPD. 95% of our clientele here are purchasing an MAPD by choice. I am not going to beat up Hospital Indemnity. We sell a lot of Hospital Indemnity. All of these products are viable. The argument, right, and this came up in a Facebook group, came up in one of the other Facebook groups, was that somebody said, hey, is the new solution selling High Deductible Plan G paired with the Hospital Indemnity plan? And I had a pretty hard line stance at first, because I thought about it based mostly on my personal experience. I'm in Texas, but I do sell in 36 states. I've also have experience as a national wholesaler. So I know what each state looks like from a Medigap marketplace. Like, I'm very aware that Florida has high rates, New York's community rated, Washington, like, I know the difference of the states. So when I thought about it from a kind of a broad stroke appeal, right? That no, I don't think that's the smarter choice. I'm still going to back it up with Plan N. I'm still going to sell Plan N. And that comes from my experience. Now, again, if I'm in Florida, totally different scenario, right? If I'm in Wisconsin and Minnesota, it still might be a little bit different because your plans aren't standardized, but not that much. California, you don't even have an option. You don't have Hospital Indemnity plans to sell in the first place. Same thing in New York. So in New York, some of these arguments in New York, California, this doesn't even play for you guys, because you can't sell a Hospital Indemnity with a High Deductible Plan G with the Hospital Indemnity plan, because you don't have any viable Hospital Indemnity plans available. So for you guys, it's out. But for most of us that aren't in some of these states that are kind of like an anomaly, I'm still going to stand up and say Plan N is the smarter choice. And we'll get into some of the math and some of the repercussions, if you will, of when someone has one or the other. Right. So again, the problem is not which product has the lowest premium. The product is, how do we get them access to care at a cost they can afford? We're looking at rate trends, looking at access to care again, looking at initial premiums. Is that smarter? Now, like I said, just going to go back real quick to retract. I took one of the worst cases available first. I looked at Miami, Florida, 65-year-old female. You have a $230 plan in, a $65 high deductible plan G, and you can plug in a Hospital Indemnity plan for about $23. So 23 plus 65 is way better than 230. So in a space like Florida, yeah, it makes sense somewhat, right? I'm still probably going to say like MAPDs probably do better, but still, how does it work? Let's think about that for a second. Because if someone has a high deductible plan G and they go in the hospital, how much do they owe? Whether they're in there for 1 day or 5 days or 60 days, and you should all know this answer. Don't rush to the comments on it. But $1,736. They owe their Part A deductible as soon as they step in and spend a night in the hospital. Right? $1,736. Now, there are some Hospital Indemnity plans that will allow you to do a hospital admission benefit. Manhattan Life and Bankers Fidelity are the first two that come to my mind. I know Bankers Fidelity, I believe Bankers Fidelity is now available in Florida for their hospital indemnity, if I remember correctly. I could be wrong. I know United National Life is out there. I think GTL is out there. Believe maybe, I can't remember if Aetna's HI is out there. And I'm not sure if Manhattan Life is out there because I don't sell it. But I know that those two products have a admission benefit. So instead of having a hospital indemnity plan where you pay per day, right? It's like, hey, I want 5 days at $300 a day, for example, to match up with my MA plan. You can write the hospital indemnity plan so that they have a single admission benefit, and you could write it to be enough to cover the Part A deductible right there. You could make an $1,800. I know you can do this on Bankers Fidelity as an example. You could write the plan with an $1,800 benefit so that as soon as they're admitted in the hospital, they can submit it no matter how many days they're in there. They're going to get their money back for the Part A deductible. Other things you could add, what the ambulance ride. There are some outpatient stuff, but most of the outpatient stuff is super limited to diagnostics, maybe the occasional outpatient surgery, right? So there are a few other ways where I can at least get a few Part B costs built into my hospital indemnity plan. But here's the problem. The more you stack into that hospital indemnity plan, the higher the premium goes. Not as big a deal in Florida, where my disparity between Plan N and High Deductible Plan G is so great. I could actually stack up an HI product in that state and still smoke the rates on Plan N and sell something viable. You get back to a state like Texas, where my Plan N rate for a female age 65 is $78.68 in the lowest zip code. A High Deductible Plan G is $28.66. That's $50. And a decent HIP hospital indemnity is still going to be about $21, and that's building it based on 3 days at $600 a day. So I kind of thought about it in a couple of ways. Number one, you have a couple of products where I can sell the admission benefit. No matter how many days you're in the hospital, pow, here you go. With Bankers Fidelity, just as an example, that rate is $34 and change. So if I write an $1,800 admission benefit for the hospital indemnity plan with Bankers Fidelity, it's going to be $34. At least that was definitely the rate in Texas and many other states that are on that product. So 34 plus 28, I'm starting to get pretty close to my $78 plan in rate. It's arguably close. I'm still saving them money, but here's my issue. If I'm going to build the product that way, I prefer them to have, this is just my preference. I prefer them to have 100% hospital coverage. You don't have to turn in a bill. You don't have to turn in anything, and you can get it a much better rate. So it's very close, man. I was actually, when I first saw this idea come up, I was real hardlined about it. And then when I started doing some math, I'm like, okay, I can see where this could play. I see some plan designs. So again, I came up with 2 plan designs. One is using Manhattan Life or Bankers Fidelity, right? You're going to need to use an admission benefit that's at least $1,800. The problem again is if you start adding in a lot of the riders, you might as well just sell a plan in, because you're going to get up to that space. Any good hospital indemnity plan with good riders is going to be about $50. 50 plus 28. Now I'm at $78 already on my plan in rate here in Texas. A few other states, Missouri, where rates a little higher, the disparity is going to be a little greater. Colorado, I see Josh Young's chirping in here. I'd love to hear some of his more comments on some of the rates in regards to that combination. Rates are a little higher in areas of Colorado. New Mexico, same problem. So it's not a hard and fast deal. But again, they're still going to have to pick up a lot of the skin in the game. So you need to be really clear with your client on, hey, you're going to pay one way or the other. Would you rather pay with a low premium? Right. So again, we can get HDG in Texas for about $28. It goes as high as $65 in Florida. That's probably pretty close to the perfect spectrum. I doubt there's a cheaper rate on HDG than $28, and I probably not one much higher than 65, except maybe in Connecticut or Maine, or probably Washington, I should say. So that's a pretty good spectrum. But if I'm going to add in a hospital indemnity plan, again, if my argument is premium, if I'm just trying to get them cheap premium, then just sell them an MAPD, because that'll always win. If my goal is to get them access to care with stability and little out of pocket when they use, I'm always going to want to go to Plan N. And what is the argument that everybody says against this job. No, don't sell them Plan N. What is the big fear-mongering argument? Everybody talks about excess charges. Excess charges are not the issue that you think they are. I would almost say that excess charges are a non-issue, period. And the math is simple on that. 99% of all providers, coast to coast like butter and toast, accept Medicare. What's more important is that 97% of all of those doctors that accept Medicare also accept Medicare assignment. It's up closer to 98% now. It increased with some of the changes they've made in the last couple of years on the Medicare physician fee schedule. So it has actually gone up. 98% of doctors all accept Medicare assignment. So what that means is that those doctors will not be charging excess charges. We have sold hundreds and hundreds of Plan Ns out of this office, and I've sold them on my own since the inception of it back in 2010. So for 16 years, this product's been out there. I embraced it almost instantly. The only Plan N that freaked me out was when Mutual of Omaha was doing them guarantee issue. If you guys go back that far and you remember 2010 when Plan N came out, Mutual Omaha made a little mistake and they gave it away guarantee issue to everybody at full comp, and it turned out to bite them in the butt. That's where some of the argument that, oh, no, Plan N has super high rate increases too. A lot of people are still attached to that singular anomaly of Mutual Omaha making a bad accounting error and thinking that they can give away Plan N guarantee issue. We all knew that, like anybody with a brain knew that was an issue. And yes, we saw 30, 40, and 50% increases on that block of Plan N business. Plan N in itself has excellent rate trends. I'm going to prove that again for you here in a minute. But again, the argument, I still believe that Plan N is a smarter choice, mainly, again, because of the lack of problems with excess charges. Every time I bring this argument up, and it's same thing happened in the group, right? Somebody proposed, hey, is High Deductible Plan G plus a Hospital Indemnity plan, is that the new way to go? And I said, no, just sell them a Plan N. And the reason, again, is because, number one, I've sold hundreds of them. I have never exactly zero, and I haven't just sold them in Texas. I've sold them in Texas, New York, New Jersey, Virginia, Georgia, the Carolinas, Arizona, California, Arkansas, Oklahoma. Like, we sell them. We have a lot of Plan Ns on the books. We've had exactly zero people in 16 years of selling it come back and say, hey, what are these excess charges? Why am I getting these excess charges? What are those? Explain those to me. And we certainly tell them about it when we sell the product, but we've never had anybody come back. I'm not saying it doesn't happen, because I know as soon as I say it never happens, there's going to be somebody's like, well, I got excess charges. And I know they do happen, but they're extremely rare. They're so rare, it's almost a non-issue. It's not a perfect zero, but it's real close. It is very, very close. And it's not even hard to train your client on how to verify whether doctors accept Medicare's assignment or charge excess charges. All they do is to ask them. And 99% or 98% of the time, if they asked 100 doctors, they're going to be told, no, we don't sell it. We don't do excess charges. We follow Medicare's fee schedule, right? So I'm going to hit those numbers again. 99% of doctors all accept Medicare. These are verifiable facts. I'm scrolling through my notes to find the exact source, because I did verify that again before I came up. I was thinking I had gotten it originally from Kaiser Family Foundation, but I got it somewhere else. It's in here somewhere. I'm just got to scroll and find the exact source. But 99% of doctors all accept Medicare. 98% of those doctors all accept assignment. Means you have about a 2% shot of going to a specialist that is going to charge you excess charges. And also some clarity on this, because in the group where we were having this discussion argument, someone made the comments like, well, as soon as they go to a specialty hospital, they're going to face excess charges. A little bit of an assumption, but I want to clear that up. The hospital is not charging excess charges. Hospitals bill under Part A. Are there things that happen in a hospital that get billed to Part B and could be excess charges? Yes. And those are going to come from the specialists or physicians that are in there, right? But the hospital itself is not going to be billing those excess charges in that specific scenario. right? It's going to be the doctor that is connected to that hospital care, so to speak. So again, here it is. 98% of clinicians billing Medicare physicians fee schedule were participating providers, meaning they agreed to accept Medicare's fee schedule amount as payment in full. This implies only 2% were non-participating, which matches the less than 3% statistic. This came from MedPAC in 2024, as well as using CMS administrative data is where I pulled that from. Pretty sure I've seen that also from Kaiser Family Foundation and another census score in the past. But that number, that 97%, 98% that accept assignment and don't charge excess charges, that has been a pretty constant number since I've been in the business. And this has been something that I've known and believed in for years. And I sold Plan In with that belief. And again, I've never had an issue. Hundreds of plans sold. Not a single person has ever come back and said, hey, what are these excess charges? Which means one of two things. Either A, they're not getting charged excess charges, or B, the excess charges are so small and minuscule and meaningless to them that they just pay them and they don't complain. One of those two is happening. I'm still in the camp that it's not happening. At least certainly hasn't happened to any of our clients. I know it does happen out there, but it's not as big a deal as people make. I hear agents fearmonger this. And listen, no, you can't sell Plan In because of those excess charges. So let's make sure everybody in the group, everybody in this call knows what excess charges are, because I see a couple of newbies in here. What are excess charges? Well, as I've been saying, 98% of doctors all accept Medicare's assignment. That means Medicare's fee schedule for all services as they write it, right? Medicare has an assigned fee for any type of service a provider can perform. So if you follow Medicare's fee schedule, you're considered accepting assignment. Now, you can be a participating Medicare provider, meaning I do take Medicare patients, but I'm not really into your fee schedule, bro. I feel like I deserve more money as a doctor. And as a doctor, I can charge up to 15% more than what is written as on the fee schedule. So for example, if a procedure on the fee schedule arbitrarily is $10,000 is the most Medicare will pay for it, but you're a doctor that doesn't accept assignment and you reserve the right to charge excess charges, you can charge a maximum extra 15%. So Medicare would pay the $10,000 along with your Medicare supplement if you're smart enough to have one. But if you had Plan In and that doctor charged excess charges, you'd be on the hook for $1,500 for that service. Okay. So that is what considered assignment is. 98% of doctors all follow that schedule. There's a measly 2%. Most of them are apparently in the behavioral health category, neuroscientists, psychologists, psychiatrists, etc. The majority of them are in the behavioral health thing. And that's actually where that 1% uptick from 97% to 98% in the last couple of years happened, because Medicare increased the fee schedule for some of the behavioral health categories. So some of those doctors are getting more money now. Most of it's related to home marriage and depression counseling, right, for lonely seniors. Some of those doctors are now getting more money. More of them has now decided to accept assignment. So it went up to 98%. So again, 2% of them are in that one little category. It's a very slim chance anybody's ever going to get excess charges. I'm not saying it doesn't happen, but that is one of the big reasons why I would prefer to sell Plan In, even if it is maybe $20 more than an HTG with the hip, is because I know the fact they're not going to get charged excess charges. It's extremely, extremely slim. It's never happened to me. And I would ultimately rather them have full 100% access to care, just like they would get with an HTG. But more importantly, they're going to get way better coverage. It's limited to a $283 deductible versus a $29.50. So their out-of-pocket is much more manageable, because if I do give them a hospital indemnity plan and package that in, I'm going to increase their premium up 50%, maybe 100% over what their Plan G cost is, high deductible G, at $28, $20 for the hospital indemnity. That's going to pay them $1,800 when they're hospitalized. It will pay for an ambulance at $300. I included that. right? But there's no real Part B stuff in there other than an outpatient surgery, which I can add another $10 premium and get the outpatient surgery paid for. Again, I'm just continuing to inflate it. The more I build that hospital indemnity plan up, the closer I'm getting to just sell them a plan in, man. There's limited acceptance for this. A couple of questions that we have in there. Yes, doctors have to disclose if they don't accept assignment. You are correct, Lori. So again, all you have to do is teach your clients, hey, before you go book an appointment with that brand new specialist that you heard so many great things about, call them and just ask them, hey, are you do you accept Medicare's fee schedule as it's assigned? Or do you reserve the right to charge excess charges? And they will 100% tell them. Sarah Copeland, does MD Anderson charge excess charges? It's not the hospital. It is the doctors inside the facility. So you don't have to worry about MD Anderson charging excess charges. But if there is a surgeon or physician that works out of MD Anderson or uses that hospital, he certainly could charge excess charges if he doesn't accept assignment. I'm of the opinion that you probably won't have that problem, but nonetheless, that would be the question to verify. Look for a few other questions in here. Nothing. All right, good. Let's look at some rate trends. I'm going to share my screen with you on for these. Let me pull them up real quick, because this is some of the meat of the conversation too, right? I mean, the whole purpose of people even thinking about high deductible plan G plus a hospital indemnity plan is to save money on premium. And they're saying, well, Medicare supplement premiums are going up like crazy. Yes, increases have been a lot higher in the last 3 years, 4 years than they've been in the past. 100%. I think in some cases, it's been a variety of things. It's certainly been medical inflation. It has definitely been an uptick in utilization, because there was a bunch of people that held back utilization for a while. That argument definitely holds weight. You had millions, I would argue, probably hundreds of thousands, if not millions, of beneficiaries back during COVID that were not getting procedures done, elective procedures, shoulder surgeries, knee surgeries, whatever, because they didn't want to go in there and get sick. So that argument definitely holds some weight, but I think a lot of it is definitely inflation as well. So where's these rate trends at? I know I've got them on here. So I specifically looked at Plan N rate increases, Plan F rate increases, Plan G, and Plan High Deductible G. Oh, they're right here. Sorry. Different thread. Here we go. And I'll share this with you guys. Give me just a second to get it right on screen, and we will look at it bottom line. Pretty simple. Share screen. Because I've had a few people complain about Plan N rate increases, and they're right. They've been higher, but they're still statistically lower. So this is the, I asked ChatGPT to do me a favor and talk to CSG Actuarial and pull some data for us. And if you don't know who CSG Actuarial is, or you don't use the quote engine, you need to crawl out from underneath the rock that you're in and get with the program, because CSG keeps their hand on the pulse of the Medicare supplement market, among many others. They definitely know what's going on with it. So from 2011 to 2024, this is average new business rate increases for F, G, and N. Plan high deductible G, I've got a little further down, right? From 2011 to 2024, it was 6% average annual increase on F. G was 5.4, N was 4.3. The compounded impact you can see here, and that is obviously compounding year over year. The average annual increase from 2015 to 24 is actually even better. 5.7 on F, 4.8 on G, 3.9 on N. And the compounded impact in those years, same thing. You can see that it's much, much lower on Plan N. So just flat off the bat, just to be clear, on the main 3 plans that get sold, it is statistically factual that Plan N has the lowest rate trends, period, in the marketplace across the spectrum of time, right? If we're just going to pick on anecdotal periods of, well, in the last 2 years, we've had carriers doing 30% rate increases on Plan N. Yes, there have been a couple. They're anomalies. That is not happening across the marketplace. How do you pick your good carriers on Medicare supplements, man? You got to look at how many lives they've got, their rate increase trends, and then more importantly, their loss ratios. CSG Actuarial's historic rate increase for 2024, and this is where, as I've said, it's been accelerating, right? As of 2024, average was 8.8 for F, 9 on G, and 8.2 for N. So it's evened out quite a bit just in that 1 year. Compiled rate increases by plan. The average rate trend in 11, right, was 9 for F, 9.2 for G, 6 for N. And it's actually, look, we had a stretch. We had this beautiful stretch down here where we had some good rate trends. And then 2024, everybody jumped up 8% or jumped up to around 8 to 9%. Equal in all. I'm not going to get into all of the what happened stuff because it is definitely overutilization, medical inflation, which is basically what that all says too. But I want to get to high deductible G real quick and show you guys some of those rate trends. Here we are. So HDG hasn't been around as long, right, as some of the other plans. It was released in 2020, so we don't have a ton of history on it. But here's what we can see. Since 2020, these are average rate trends on HDG, Plan G, and Plan N. And you'll notice, obviously, Plan N has taken a little harder in the last couple of years, as all Medicare supplement plans have, even Plan HDG. In 2020, the average increase on HDG was 0.7%. I mean, that was the year it got released, so not much going on there. 1.5%, 0.3%, 2.8, 4.6, 6.5. So everybody's been going up to, in the last 2 years, a little more excessively. Surely that has got to flatten out at some point, right? Those types of increases can't sustain themselves year over year over year across the marketplace as an average. So they're going to stable out, which means definitely HDG is going to drop back down to its reasonable, probably 3%. And I would say Plan N, same kind of concept. So again, a blanket sweeping statement that Plan N has terrible rate increases is not really correct. You're seeing some anecdotal examples out there for that. It definitely has a very mild, so does HDG, obviously, has mild trends. So again, it's going to keep the argument fairly close, and it's going to keep it very regional, etc. If I am looking at, hey, do I sell a Plan N here or do I sell an HDG with the HIP? I would still always tell you to sell a Plan N unless you are maybe in Florida where the disparity is so great. But let's say in Texas, again, if my difference is only about it's about $28 difference in premium. That's a pretty good chunk of change. $28 for some of these people. I mean, that's almost $360 a year in premium savings. But I'm putting them at the expense of a $2,950 deductible, which personally I don't like for most of my senior clients. There's not too many of them that I talk to that want to deal with that. We deal with a little lower income folks too. So I know some of you probably wanted me to hear just completely rip one of the sides of this argument, but it's honestly, it's going to be a preference thing for most people. I would prefer to protect my clients so that when they're hospitalized, they're not having to collect receipts, pay bills, turn them in, and get reimbursed. And also still be subject to a bunch of additional cost, right? Because unless I build my hospital indemnity plan with an admission benefit of the full $3,000, which they may not even spend because, again, their hospital deductible is only $1,736. So if they have a high deductible plan G, they go in the hospital for 1 day, that's $1,736. They're done there. Anything else is going to be Part B charges, which I may not be able to cover with the hospital indemnity plan. So if I did, I could make that admission benefit $3,000. And when I do, my HIP product is now going to be closer to $50. $50 plus 28 is the cost of a plan in here in Texas. And that's going to be very similar in most states. We're still going to have some outliers. So that's my thoughts on the subject. I beat this up a little bit in my head last night, and I was looking at rates in different states. I was comparing Connecticut. I looked in Nevada. I looked in, I didn't bother with New York because you can't sell any. I looked in Maine. I certainly looked in Florida. I looked in Texas. And with very few states, like Florida was the only one that like really stood out as the anomaly that it is. All the other states, you're going to see the rate is way too close to just, in my opinion, to use HDG and HIP as a premium saver, considering that the sacrifice is going to be the extra work of having to pay up front, getting the reimbursement, et cetera, right? So I get it. I see people are trying to get creative out there, man. I would say don't overthink it. Certainly be creative when you can. Don't bundle products just for the sake of making extra money. Bundle them when it's right for the client. It's going to give them the type of experience that you want to give them or that they want, certainly, right? I love to bundle products. One of my last Medigap sales was 5 apps in total: Medicare supplement, dental, vision, drug plan, home health care plan. So I definitely am all about bundling, but just make sure you bundle it right. Don't bundle just for bundling's sake. So to come back to Sarah Copeland's comment regarding regular old Plan G, that you have people that are adamant about it. I got no problem with that. People want to be adamant about Plan G, be adamant about it. It's a great plan. You have a $283 deductible and you're done paying. You have the closest thing I can get you to first dollar coverage. I have 2 clients that I'm working with right now. Same thing. I'm of the opinion Plan N would actually work great for them because they're actually pretty damn healthy. They don't really need to go to the doctor much, and they have a lot of cash. So they can afford the extra couple of co-payments they might have on Plan N versus Plan G. But even then, like, if you do the math, how many times do I have to go to the doctor on Plan N to make it more expensive than Plan G? And for most of those people, it's not the cost. It's the exercise. It's the trouble. And that's where this guy was at. He's like, I know that you can do some math. There's a math equation you can do to figure out why Plan N is a smarter choice mathematically for me. Like he's kind of a very green personality engineer type. He's like, but I don't care about that. He's like, I just want Plan G because I don't want to have to worry about it. Right. He's like, I don't care about the extra little math, whatever. He's like, just give me a Plan G and let me go on about my business. So this was one of those guys that I actually made a post about him in the Insurance Syndicate group earlier last week or so. Don't argue with the marketplace. Just sell it what it wants, right? I know a lot of times we like to tell them how smart we are with our genius ability to design plans and do things and show them all of the reasons why they should do this versus that. But most time, just sell them what they want, man. Don't argue with them. If the guy wants a high deductible, or if the guy wants a Plan G, period, even though you could save him money on a Plan N and get him as good or better health care, don't argue with him. Just write him the Plan G, let him be happy, and walk out. So fairly simple. So I appreciate some of the compliments I got in the group that it was a good training. A lot of this was off the cuff. I had done some data research and kind of put it together. And again, I even softened my position a little bit because I can definitely see where it makes sense in some areas. But ultimately, from a broad stroke, I'm going to tell you that just writing folks a Plan N is a way better solution to protect them long term. So, but ultimately, sell the market what it wants. See you guys next week. Have an awesome, awesome week. And hit me up if I can help you. Take it easy.